Good. Good morning, everyone, and welcome to our eLotus webinar. Happy Super Bowl Sunday. Happy Chinese New Year Eve. It's good to have you guys here join us. It's going to be a great class. My name is Donna Chow, and I will be your host and your moderator for today's class. So if you're here looking to learn the clinical applications and clinical stuff that actually works in your clinic, you have come to the best place. Here at eLotus, we pride ourselves on being the largest online CEU platform for acupuncturists. We have over 1,500 hours of CE courses and over 80 speakers, over 80 experts that you can learn from. And we wouldn't be here today without our sponsorship, Evergreen Herbs. So at this time, I'd also like to thank all of our Evergreen customers joining us today. A little housekeeping before we get started. What you are seeing on your screen. Top left-hand corner is the video feed. To the right of the video feed is the PowerPoint for today's class. You are able to download the PDF file of the slides, and you can find them on the Blue Course Access page. The bottom, you'll see 3 boxes. First box to your left is the chat room, and here in the chat room is where you can connect with your colleagues who are chatting from all over the world. Right now I see Fresno, Sacramento, and North Carolina. Welcome. And the last 2 boxes to your right, you'll find upcoming eLotus events and also information about our sponsor, Evergreen Herbs. If at any time during today's webinar you experience any slowing, skipping, or stopping, you'll want to first check your internet connection. Usually this happens when the user is on a wireless connection. So if you can, we highly recommend that you connect to the internet directly using an Ethernet cord. If that's not possible, the next best thing is sit closer to your router. And if you do need any help, technical assistance, please private chat with either Sam, our tech, or I, and we will be happy to help you. If you're logged in more than once for today's webinar, you will hear an echoing sound. To resolve that issue, just close the extra login, or after a period of time, the Adobe interface does remove the extra login for you. And let's see, and then today's webinar is being recorded, so you guys will have a chance to review the material, and I'll send an email out on Monday when the video recording is ready. Okay, so today's webinar is Western Reproductive Medicine for Eastern Medicine Providers with Dr. Kalan, who is a double board certified in reproductive endocrinology and infertility and in obstetrics and gynecology. Dr. Kalan completed a 3-year fellowship in reproductive endocrinology and infertility at USC, where he also completed a 4-year residency in OBGYN, serving as chief resident in his senior year. Dr. Kalan earned his medical degree at the Chicago Medical School of Rosalind Franklin University and completed his undergrad studies at the University of California, Santa Barbara. Dr. Kalan focuses on the treatment of infertility through a variety of modalities, including stimulated and natural IVF, genetic screening, and oocyte cryopreservation. Additionally, Dr. Kalan is an accomplished microsurgeon who is an expert in the art of tubal reanastomosis. Did I get it right? Close. Oh, darn. Okay. All right, so let's I was trying really hard to get that word right.
Reanastomosis.
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 Okay, there we go. I finally got it. All right, let's give a big welcome to Dr. Kalan.
Hey, thank you. All right, good morning, everybody. And welcome to Super Bowl Sunday edition of Reproductive Medicine. Thank you, Donna, very much for that lovely introduction. And I think before I get started, I think it's worthwhile kind of just talking about because I was listening to all those things that you were saying about me, which sounded pretty nice. I think it would make my mom really happy. But I think it's worthwhile kind of talking about, like, what does that really mean? Who all those different things. So essentially, amongst the world of fertility specialists and people who do different types of fertility medicine, all the credentials mean different things. So to be double board certified, what that essentially means is that once somebody goes to medical school and finishes medical school, then they have a choice of what they want to specialize in. And you can specialize in everything from internal medicine to family medicine to general surgery to orthopedic surgery, dermatology, neurology, whatever it may be. And so I specialize in OBGYN, which is the normal route for anybody who's going to eventually go on to become a fertility specialist. And you do a 4-year residency in OBGYN throughout the United States. And then after that residency, you can choose to become a general OBGYN, and that's somebody who usually practices obstetrics, maybe some office gynecology, does general types of gynecological procedures and whatnot. Or you can then subspecialize, and you become board certified in that if you choose, which, like for, I know that there's boards of Oriental reproductive medicine and different types of boards, and the same kind of process where you sit for a study, you have cases, and you sit for an exam. Or then you can subspecialize, which is another 3 years of training in any one of 4 different subspecialties out of OBGYN. And so myself, Dr. Winkler, who spoke yesterday, and any other board-certified reproductive endocrinologist does a 3-year specialty in reproductive endocrinology and infertility. And then you learn all about any type of reproductive hormones. You do reproductive surgery. You do in vitro fertilization, and a certain amount of research within those fields. And then you sit for a board exam. So that's where all of those letters and all that stuff comes from. It's worth knowing about, just because, you know, anyone can call themselves anything, but it's good to know what the credentials for whomever is calling themselves what they're calling themselves, what those credentials come from. So that's my kind of story. Okay, so without any further ado, I'm going to talk about Western reproductive medicine in the context of what Eastern medicine providers, to kind of bridge the gap between what you do as Eastern medicine providers and what a patient may come to a Western reproductive medicine doctor for. And bringing that together is a really great way to help our patients. So I'll start with, I really like to, when I'm going around in life, I kind of notice my surroundings. And I've been taking pictures for a while of graffiti that has the word life in it. And this is a really cool one. I like to surf a lot, and I was driving up the coast in California and stopped at a local beach I like to go to, and there was this kind of interesting graffiti on the walls that life takes time. And I kind of pondered that for a while. What does that really mean? Like, you know, does it take time? Does it take time to live life? Does it, you know, it's just kind of a cool little idea. So life does take time. So today we're going to talk about a bunch of things. We're going to talk about embryology for a little while in terms of the formation of the reproductive organs. We're going to talk about female reproductive anatomy and how it relates to the menstrual cycle and ovulation. We'll talk a little bit about conception, how conception occurs. We'll then talk about female reproductive disorders. And we're going to spend a lot of time on things like PCOS. We'll then talk about some male reproductive topics, including the embryology of the male reproductive system, anatomy, sperm production, semen analysis, the interpretation of semen analysis, and causes of abnormal sperm production. We can also talk about unexplained infertility. And if we need to, we have a little more time, there's a couple more bonus topics we can talk about after that. So I kind of like this saying, a hen is only an egg's way of making another egg. You know, it's all about the egg, not about the hen. So ovulation. Ovulation represents the episodic spontaneous extrusion of a mature egg from the ovarian cortex into the peritoneal cavity. And this picture up here is a laparoscopic view of an ovary. That's what this structure is right here. And this is a follicle that is getting ready to break open and release the egg from it. I think that the visualization in people's mind of what an ovary is, it can be kind of difficult, and how the eggs exist within those ovaries. One of the analogies I really like to use in general is if you think of the ovary like a scoop of bubblegum ice cream, and within that scoop there's little pieces of bubblegum stuck throughout it. Those bubblegum balls inside the scoop of ice cream would represent the follicles. And what essentially happens is every month one of those bubblegum balls will blow up a bubble, and that is the developing follicle, the dominant follicle that we'll talk about. And when that bubble bursts, the egg which is inside comes out, and that's ovulation. So this is what it looks like from a laparoscopic point of view. So until about 5 weeks gestation, which is about 21 days after fertilization, males and females have the same pregonads. And this is actually a point worth stopping for a second here. So notice it says 5 weeks gestation, which is 21 days after fertilization. So just to review, gestational age is always from the first day of a woman's last menstrual period. That's how we date pregnancies. So, but what that is that assumes 2 weeks of that time a woman is not pregnant, because from the first day of her period to ovulation is assumed to be 14 days. And then at the point of ovulation is where conception occurs. And then 2 weeks later is when a woman misses her period, and generally when she can have a positive pregnancy test. So when a woman has a positive pregnancy test, she's actually only been pregnant for 2 weeks. That's since ovulation has occurred. But by convention, that's actually 4 weeks of gestation. So when a woman has a positive pregnancy test, she's already 4 weeks pregnant. And a full-term pregnancy is considered 40 weeks. So at the time you have a positive pregnancy test, a woman has a positive pregnancy test, she is 4 weeks into a 40-week pregnancy. So there's only 36 weeks to go. So in terms of the embryology, at 5 weeks gestation, which is 21 days after fertilization, 3 weeks after fertilization, males and females have the same pregonads. Gonads are the reproductive organs. And those gonads are a mesothelial thickening, which becomes what's called the gonadal ridge. And this is the precursor to the testicle or the ovary. And just a quick review back, the mesothelial thickening during embryology, there's essentially 3 types of tissue. There's the endoderm, the mesoderm, and the ectoderm. And the mesoderm, where the mesothelial thickening is the middle layer. The endoderm is the tissue that goes on to become like the inside of the intestine. The mesoderm goes on to become organs like the gonadal organs, and the ectoderm goes on to become the outside, like the skin. So this is just a picture of a schematic of a human embryo at around 5 weeks gestation. And essentially what you see here is the gonadal ridge would be up around this area. Okay. So if at this time, you can remember at this point, this could be male or female, it would look exactly the same at this point. So at this time, if there is a Y chromosome present, making the embryo male, the cells within that gonadal ridge will become a testicle. If a Y chromosome is absent, the cells within that ridge will become an ovary. So it's sort of like the default is to become an ovary. It's in some ways, from an evolutionary point of view, if there's any errors, we would default to become female as opposed to male. Maybe it's more important that we create females and males. That could be the way we look at this. So if a Y chromosome is present, then the testicle forms. And if the testicle forms, then the tissue begins to make a few hormones named testosterone, which we all know about, and anti-Mullerian hormone, which we may have heard about. We can talk a little bit about it more later. And the testosterone, as well with some other androgen hormones, goes on to direct the development of the internal and external male genitalia. These are known as the Wolffian structures. The anti-Mullerian hormone prevents the production of the Mullerian structures. So, in this drawing here, the Wolffian structures, which is the male structures, are these things, the things like the epididymis, the vas deferens, the seminal vesicles, and this over here is going to be the Mullerian structures, which we talk about. But this is the key. So if the testicle is there, the testosterone causes production of these and prevents production of these. The AMH, the anti-Mullerian hormone, prevents production of these. If the Y chromosome is not there, or in some situations not functioning, then the testicle doesn't form. Testosterone is not produced, and so if testosterone is not produced, these will not form, and the anti-Mullerian hormone will not be produced, allowing these to form. So the Mullerian structures, include parts of the uterus, the upper third of the vagina, and the fallopian tubes. The Mullerian ducts are the precursors to the fallopian tubes, uterus, and upper third of the vagina. The Mullerian ducts are cylindrical structures which migrate medially across the embryonic disc during the 6th week of gestation. So, actually, we'll go back a couple slides. Remember, we're talking about in this ridge, this would be the disc, and so the Mullerian structures are going to be starting off kind of laterally on either side of this disc, moving more centrally. Okay? And then I went and did some really fancy PowerPoint animation here. And this is sort of what we'd expect to look like. So here's our cylindrical structures that would be on either side of the embryonic disc. And they migrate towards each other during the 6th week of gestation. And then what happens is the caudal end, which is the end towards the tail. Actually, I'll go right back to this again. Remember, this would be a cut through of the embryo. The tail structure would be down here. The rostral, or towards the head, or actually rostral comes from beak. Remember, this is an embryo, but it's animalistic at this point. The tail's down here. The rostral end would kind of come out this way. So we're talking about the caudal, or the lower end, that's coming down this way. So coming together. And so in the caudal end, these ducts meet in the midline and fuse together to form what we call a double lumen structure. And then the tissue separating those two lumens begins to resorb by the 9th week of gestation. And that's how we form the uterus and upper third of the vagina. That's this tissue right here. Okay? And as that kind of resorbs up, this begins to form a structure that becomes more recognizable to us. And eventually, this is my fancy PowerPoint drawing, but this would be the uterus coming into the vagina with the fallopian tubes coming out like this, and the ovaries show up right here. And this is this is kind of what this looks like in real life or during surgery, for example. Remember, this is the uterus here, going out to the fallopian tubes and coming down into the vagina. And this sits in the pelvis right about here. In most women, the uterus actually does kind of fold upwards. So it's sort of the top of the uterus is kind of pointing towards the belly button. But the uterus can also fold downwards. It's called a retroverted uterus. and the fallopian tubes kind of flop out. Interestingly, in a lot of diagrams, they're structured like this, where the fallopian tube kind of comes up and then engulfs the ovary like this. That's completely inaccurate. The ovary is completely independent of the fallopian tube. The fallopian tube never engulfs it at all. So this is what a laparoscopic view of the pelvis looks like. And essentially, when we do a laparoscopy, just for context, essentially what's happening is there's a camera which goes down through the belly button, and that camera is your view of the body. So in this setting, in this drawing here, this would be like the inner part of the right thigh. This would be the right labia. This would be the say the belly button right here, and then this would be an instrument here. The patient's head would be off this direction, and so this would be as if there was an incision all the way down through the middle, and you're looking through the side. So the view we have when we're doing a laparoscopy is from this camera. And so one of the best ways to kind of think of that view is if you were to miniaturize yourself and stand in the belly button and then take an elevator straight down and you're looking this way. So picture yourself now standing here looking down towards the feet. And what that looks like is sort of like this. So now you're standing looking straight down. This would be off to the left. This would be off to the right. And here is the top of the uterus. Okay? Here is the left ovary, and here is the right ovary. Here's the fallopian tubes kind of coming out this way and this way. So I think context is really important. Remember, this is you looking this way. Fallopian tube, this would be the right ovary. Remember, here's the drawing. It shows a fallopian tube coming in and engulfing the ovary. Totally inaccurate. It doesn't show the left one because it's kind of cut off. And so this is that view now from the other direction, looking straight there. Right ovary here. Right fallopian tube kind of comes out like this. Left ovary here. Left fallopian tube out like this. Okay, so now that we kind of have an idea of what normal reproductive anatomy looks like, we can talk about some of the structural abnormalities that we all encounter in patients during practice. One of the more common ones that we see is something called a septate uterus, or when the uterine cavity has a septum within it. Excuse me. Oh, by the way, I really like to interact. Normally, you guys can't see this, but normally I'm in a room talking about this, and there's a whole bunch of other people, and I get to pick on people and ask them questions and see if someone's paying attention or not, or kind of get a sense of if what I'm saying is making sense. So I'm able to see your comments on the screen over here. So if anybody has any questions for me, or thinks something I'm saying doesn't make sense, or thinks something I'm saying isn't right, I welcome you to make the comments. I'm happy to discuss it further.
Can you repeat it? So is this the ovary? Is this the fallopian tube is like this?
Oh, okay. So I'm going to do. So I've been known to do. I call this the uterine dance. So here's what we're going to do. I'm going to stand up here. Can you see me? Okay. Okay. So if my body is the uterus here, okay, the ovaries would be kind of like here in my armpits, okay? The fallopian tubes would be my arms like this. And then what happens is the gravity sort of lets it sit back like this, and the fallopian tubes kind of hang down like this down here. So the ovaries are still kind of up in my armpits, but the fallopian tubes hang down back here. And then, side view, like this. Then what happens is when ovulation occurs, remember that very first picture, how the ovary would be right here and that little bleb pops out. The fluid pops out, and then it comes and that fluid collects in the lowest part of the pelvis, which is called the cul-de-sac of Douglas, named after, I think, Dr. Douglas. And the ends of the fallopian tubes, which are called the fimbria, which have these finger-like extensions, then flop down into that little lower cul-de-sac. And if you are to see the fimbria of a fallopian tube, when it gets into water, it almost looks like, or into fluid, it looks like the ends of a sea anemone. It blooms, and all of this surface area extends. And then what happens is the egg, which is now floating in this little pool of fluid because it came out of the follicle, which is in this the lowest part of the pelvis, that is floating in there, and the fallopian tubes, the fimbria, have now bloomed out, and there's all the surface area, and the egg just gently sort of lands on the end of the fallopian tube, which then ushers it into the rest of the fallopian tube towards the uterus. And that's where, in that fallopian tube, that's where the sperm is, and that's where fertilization occurs.
So the fallopian tube never touches the ovary?
No, the fallopian tube never touches the ovary. The end of the fallopian tube never touches the ovary.
It catches the egg.
It catches the egg in the pool of fluid in the bottom of the pelvis. The fallopian, yes, that's a great question. The end of the fallopian tube never touches the ovary.
Question.
Oh, question. It moves by peristalsis. Yes, that's a really interesting question. There is some peristalsis action. There's some ciliated action in there. But yes, the fallopian tube does have some muscle once you're in the fallopian tube itself. Very little amount of muscle. But there's also like a ciliated action, these little hair cells that are moving the egg down towards the fallopian tube. But in the fimbriae itself, there is no muscle. There is no because peristalsis is a synchronized muscular movement, and in the fimbriae itself, there's no muscle cells. Ciliary, yes. Ciliary coming from cilia, which are these tiny microscopic hair-like structures that can wave and move. Okay. All right, now that we're all up and moving around. Is that okay? Isn't it cool? It's so cool. Yeah, the cul-de-sac of Douglas. It's all about the cul-de-sac of Douglas. Okay, so uterine structural abnormalities. Has anyone ever heard of a uterine septum? I don't know. Like in the trachea. Yes, like in the trachea. Yes, the trachea. There's lots of examples within the body where these hair-like structures move microscopic things all the way around. Like in my lungs right now, in the respiratory tract, there's a lot of this type of movement to move mucus and things around. I don't know if you can tell, I'm a little stuffed up, and my cilia are probably not working as well as they should be right now. Okay, so thank you for the dance. Okay. So a uterine septum is when there's an extra piece of tissue remaining inside the cavity of the uterus that's not supposed to be there. And so this would be a cut view of the uterus. And essentially what happens is the top of the uterus is up here. The sides, this cavity is supposed to be like a nice diamond. But what we have is this extra tissue right here that's in the middle of the cavity that's not supposed to be there. And the way that gets there is that, remember back to our fancy PowerPoint demonstration, these Mullerian ducts, which are on the sides of the embryonic disc, they migrate towards each other like they're supposed to at about 6 weeks gestation, which is about 4 weeks after fertilization. They come together the normal way. And remember that structure in between the two cylinders, that's right here. So the uterus begins to form, and what happens, though, is that structure never resorbs completely. And so instead of our picture before, where we didn't have this line because it resorbed all the way up, the uterine septum is when that remnant remains inside the cavity of the uterus. And so what you get is this uterine structure right here, and then this is the septum. So that's what my drawing is supposed to represent. This is a picture from an HSG, a hysterosalpingogram. So for those of you who are not familiar with what that is, that's a test that we commonly do that tells us a few different pieces of information. One, well, let me tell you what the test is. So it's a test where a small catheter is placed into the uterus, and then a radio-opaque dye is injected through that catheter into the uterus. And that dye then travels up into the cavity of the uterus and then out through the fallopian tubes. So it's used to diagnose a few things. One, it's used to diagnose if there's a blockage in the fallopian tubes, because on the X-ray, when you're doing an X-ray, the dye goes up and it goes out through the tubes. You would see it actually. This dye down here is from that. It's hard to see in this particular picture, but the dye comes out and then fills in the rest of the cavity, so you know that fallopian tubes are open. But it also tells us a lot, makes a negative image of the inside cavity of the uterus. And so when you look at this, what this looks like is the dye is going up and over to here, and up and over to here, and you get this wedge shape right here. That wedge shape is that remaining tissue that's right here in the cavity of the uterus. And that's what this is supposed to represent. This is problematic because when an embryo comes in, it comes in through the fallopian tube here after fertilization. It comes in and it usually implants right in this area, okay, middle of the uterus somewhere. Now, this tissue is not as well vascularized as the rest of the uterus, which is very well designed to accept an implanting embryo. And so what we see is that an embryo can come in here, it can implant, and you can imagine it would implant here and we get all this new blood formation if it was implanting in a healthy part of the uterus. But if it's implanting, say, here, there's not the same type of blood flow and nutrient support, and it increases the risk for miscarriage. And so it's not uncommon that in women who have recurrent miscarriages that we identify something like a uterine septum. Now there's other type of uterine structural abnormalities as well. One is called a bicornuate uterus, or a double uterus. And here's where we see you get, instead of, you recognize the difference between this one and the one before. So on this one, the top is pretty normal. This also looks kind of like a little heart-shaped. In this one, the top drops totally down. Now, interestingly, if you just look at this HSG, you see that you can just see this part, and you got this wedge of tissue here. If you look back to this HSG, you got this part and this part, you got this wedge of tissue here. There's no way to identify necessarily the difference between a septum like this and a bicornuate uterus like this just by the HSG. So you need other information telling you about the shape of the uterus. Because with a septum, we can fix this pretty well. We can do a surgery where we come in here and cut this out. Okay? We just go from the inside and cut it out. But if we were to go with that same approach, put a camera into here on this thing and try and cut this out, we would cut through the top of the uterus. That would be a big problem. So you need to make the difference. You need to identify the difference between a bicornuate and a septum if you're trying to treat it. So the way the bicornuate uterus forms is, again, we have our familiar Mullerian ducts, which move from the sides of the embryonic disc. And they move towards each other. And then what happens is, instead of completely joining at the bottom, they don't completely join. It's just the very bottom part of them joined together. And you get incomplete fusion, essentially. Everything else forms normally, but you get this big wedge that fails to resorb. And that's how you get these two wedges of uterus. And that's the bicornuate uterus. Okay. So we'll talk a little bit about the blood supply of the uterus. Is there abnormal menses with a septum? Oh, that's an interesting question. Actually, usually not. Not necessarily. Abnormal menses is not a way that we diagnose it. Most people who have a septum have no idea about it. And the reason why is that the tissue, the menses, all comes from tissue that grows here, and you get decent endometrial tissue to form all along here, and it responds appropriately to the hormones and ovulation, all this kind of stuff. The problem, and that's why you actually get implantation here. The problem is deeper down, and when the embryo starts requiring greater amounts of nutrient, that's when you run into problems. So the endometrial tissue that even forms over this septum is totally normal. That's actually the problem, because it's so normal you get implantation, it just can't support the embryo once it starts requiring greater amounts of nutrition. So the menses is normal. It's just it's once there's greater requirements of that tissue, it isn't able to support the embryo. I understand that a bicornuate uterus you don't operate. How does this affect implantation and menses? That's a great question. Yeah, so, well, a bicornuate uterus, there actually are surgeries that can be done, and we were doing surgeries a while ago. There was ways where we could do reunification surgeries. They just don't work very well. So there were, what we would do, and we're really not doing it very much anymore, is you can cut, essentially, you open up this cavity here and this cavity here, and then bring them all back together. So it was a very extensive surgery, and it just didn't work that well. So you can get pretty good implantation in a bicornuate uterus. The thing that's a little bit more tricky about it is, even though in this drawing you get these perfectly evenly shaped uterine horns, what we often see is that one is quite a bit bigger than the other. So if you get implantation in a small horn, that one usually doesn't have the same sort of support and vascularization as the bigger one. And so you get losses that are more common in that side. Sometimes what I've had of some patients who have had discordant sizes of uterine horns, what we'll do is we'll do an insemination when we're ovulating on the desired side, which can work pretty well, or we do IVF and just implant in the better horn. And that's one of the things that we can do. Does this cause a lot of scar tissue? If so, yeah, the surgery of a bicornuate uterus does cause a lot of scar tissue, and that's why we don't do it very often. So the treatment of it is usually better to make sure it's in the better horn. Now, for a woman who maybe has had several losses with the bicornuate uterus, there's not a lot that can be done, about the uterus, but sometimes we'll move on to talk about like surrogacy and stuff like that. So we're using her eggs, and then we end up, finding someone else who's willing and able to carry the embryo. But we can definitely give it a try if someone's willing to do it with a bicornuate. Pardon me. Okay, uterine blood supply. Very interesting stuff. And you guys are asking great questions, by the way. So the uterine arteries, which are the main source of blood supply to the uterus, arise from the hypogastric arteries. And they reach the uterus at about the level of the cervix. And from there, they descend into the lateral wall of the vagina, and they ascend along the uterus and continue below the fallopian tubes. So this gets very kind of complicated and tortuous throughout here, but you get this blood supply that kind of comes in through here and goes up this way, and then also goes down this way. And there's so much, you can see how it like becomes a crazy web all throughout here. There's actually some supply coming from this direction as well, but it's all really important because you wouldn't want, if there was a blockage, say, and you don't want a blockage, if something happened and you lose one vessel, you don't want to take the chance that you lose everything to the uterus. So there's a lot of redundant blood supply going to all of the reproductive organs. This is a really neat picture. This is like an angiogram of the uterus. And what you can see is how much redundant supply from both sides there are. So this is the hypogastric artery coming into the uterine artery, which is going up like this. And and over here too. There's also blood coming in from this direction here. Then all of these kind of double back and cover. Again, the body, there's a great amount of priority which is placed on maintaining the blood supply to the uterus. Interestingly, a non-pregnant uterus gets about 10 cc's of blood per minute, like pumped to it. A pregnant uterus gets somewhere between 10 and 15 times that amount. So this also is designed to be able to really ramp up the supply. And amazingly, at the time of delivery, like at the time of a C-section or something like that, you can look, and these blood vessels are, they're like hoses. They'll be as big as a pinky finger, which can actually be kind of scary at the time of surgery, because you don't want to nick any of those things, obviously. So the blood supply to the uterus, because it's just sucking in blood, which is where all the nutrients and all the support for the pregnancy comes from. So, talk a little bit about the endometrium. So the endometrium is the layer of tissue inside of that uterus that is designed to support the pregnancy. And it's a multi-layer lining inside of the cavity, which is continuously changing throughout the menstrual cycle. And there are really three main phases of the endometrium. There is what's called the proliferative phase, there's the secretory phase, and the menstrual phase. These are really important things because you hear doctors talk about the proliferative phase of the cycle, secretory phase of the cycle, follicular phase of the cycle, and luteal phase of the cycle. And actually, through the beginning of residency, when I first started, I was still a little bit confused. Like, they'll say the follicular phase, they'll say secretory phase. And no one ever explained this to me in a very frank way. So what this means is that the proliferative phase of the cycle refers to the endometrium between the time of the beginning of the period and ovulation. So that's the time that the endometrial tissue inside of the uterus is proliferating. That is synchronized. That's occurring at the same time of the follicular phase of the cycle. But the follicular phase of the cycle refers to the ovary and the follicle and the growth of the follicle. So the proliferative phase and the follicular phase are the same thing. They're just referring to different parts of the organ. The secretory phase of the cycle refers to the time of the cycle between ovulation and the next period. And that is when the ovary, that is when the endometrium is sort of receptive for the embryo. This is the same time in the ovary. That's the luteal phase of the cycle, and that's once ovulation has occurred. So the proliferative phase and the follicular phase are at the same time. The secretory phase and the luteal phase are at the same time. So just a bit to make things clear. Now this is a scanning electron micrograph of the endometrium, which I think is really cool. And so what you could picture is if you are an embryo floating down through the uterine cavity, you're going to land into one of these little nooks and crannies and just kind of wiggle your way in there and get nice and cozy. So there's all this really cool, extensive surface area that you could kind of just implant here, and you make contact. And then once you make contact, then the embryo begins to grow and extend out into these little nooks and crannies. And this is also that the endometrium is receptive to get that embryo where it's coming in to implant. This is a good thing to keep in mind when we're actually visualizing implantation occurring, because this is, I think a lot of people are concerned that, the embryo is going to come in and then could it fall out? Could it end up in the wrong place? Or, if I stand up, if I do something wrong, is it going to move around? The embryo, remember, it's a microscopic little structure that's coming in, and this is where it's like getting stuck. I almost think of it like dust falling into a shag carpet. And so the scale of this is as follows. A fertilized egg is roughly 100 microns in diameter. And so that's about 1/10 of a millimeter. And that's like, that's a little bit smaller than a grain of sand. This is just below what the naked eye could see without the aid of a magnifying glass or a microscope. Excuse me. So this is a little dorky math, but we're going to do the volume of an embryo based on it being 100 microns in diameter. You use the formula 4/3 pi r cubed, and what that comes up with is about 0.000005 cubic centimeters. Okay, so the endometrial cavity, if we figure out what the volume is of that endometrial cavity, we're going to assume that the cavity itself is about 5 centimeters wide by 5 centimeters long by about 1/10 of a centimeter thick. And so that gives us about 2.5 cubic centimeters. So if we compare that 2.5 cubic centimeters to that 5 times 10 to the minus 6 cubic centimeters, we get about 4.8 million times larger is the cavity than the fertilized egg. Okay, so keep that in mind. 4.8 million times bigger. So what that means is, and this is perfectly apropos for Super Bowl Sunday, if a football field is about 360 feet long by 160 feet wide, that gives you an area of about 57,000 square feet, or 5,351 square meters. Okay, so if you take one field, okay, and then you take another area of another football field, and you put it above it, like you're sandwiching them together, and you separate it by about a meter. Okay, so we're scaling this whole thing up. That space in between there is the equivalent of about 5,100 square meters. So now, if you take that space and you divide it by 4.8 million, you come up to about 1.6 times 10 to the minus 3 cubic meters. And if you figure out what the diameter of that would be, it comes out to about 0.14 meters, or about 5.5 inches, which is about the size of a grapefruit. So, if you were to take the field in San Jose, where they're playing the Super Bowl today, and you got all the players off of it, and you took a grapefruit. Okay, we'll talk about that in a second. You took a grapefruit and you put it right in the middle of the 50-yard line of the game today. And then you took another football, and then, just for ease of memory, we covered that field in Jell-O for about a meter. And then you took another football field and slapped it on top of it. That grapefruit would be about the size of the embryo inside of the uterus. And so if you took that whole structure and moved it around and tilted it upside down and this way and that way, that grapefruit's not going to go anywhere. So it's not going to fall out of the uterus. It's not going to move around. It's in there very safely. So the properties of surface tension totally overcome the properties of gravity or anything else like that in terms of an embryo implanting in the uterus. So there's a question about the volume of the uterine cavity. How much is the normal amount of blood that should be lost during menses? Yeah, it's a little off topic, but it's a good question. There's actually been studies that have looked at this. Interestingly enough, the normal amount of blood that's lost during menses is about 80 cc's, 80 milliliters throughout an entire menses. That's quote unquote normal. That comes from studies of actually just measuring the fluid from menstrual pads. This was done a number of years ago. So it's actually not that much true blood, but about 80 cc's is what is average. Okay. So that's the context of the endometrial cavity. Again, now the ovaries, kind of talked a little bit about them before. Here's another picture of the ovaries. We'll talk a little bit more about the anatomy of the ovary. So an ovary is a glistening white structure right there. Uterus, fallopian tubes. Remember, the end of the fallopian tubes are now down here. So the tube kind of wraps around, and the end of the fallopian tubes here and down here. Now, the outer part of the ovary is where all of the eggs are. This is called the cortex. And the cortex of the ovary is cellular connective tissue in which all the follicles are embedded. And it's surrounded by a single layer of cuboidal epithelium called the germinal epithelium. The inner part of the ovary is called the medulla, and this is where all the blood vessels and nerves and all that kind of stuff is. So this would be a cross-section of the ovary. And throughout the ovary, so this is the cortex is all out here, like this. And the medulla is this inner part where all the blood vessels are. Okay, so it's really important because there's no eggs deep inside the ovary here. They're all in the cortex out here. And remember, so this is our scoop of bubblegum ice cream, and these are our bubblegum balls distributed throughout the ovary. Okay. This is what it looks like on cross section. And so what we have here, again, this is all ovary. It's a cut through. And these are our follicles. Here, here, here. These clearings of fluid. The egg is microscopic, even smaller inside of there. This would be the oocyte right here. And this is magnified a little bit. This is probably a 10 times magnification. Here's the inner part of the cavity. Inner part of the ovary, the medulla. The ovarian blood supply is kind of redundant. We looked at it before. The ovarian artery comes directly from the abdominal aorta. And think about that how important it is. There's not many arteries that actually branch directly off the aorta, and there's one that's going directly from the aorta to the ovary. That's how important the blood supply is from to the ovary. It separates into multiple branches that enter the ovarian hilus, and each artery divides into 2 branches which cross the ovary, again, for the redundancy of this process. And here's a picture of this. So here's the aorta. The heart's going to be up here a little ways further. And you can see how it's not like every organ gets its own supply straight from the aorta. There's, the aorta's it's really important. But here's from the right going down to the right ovary. The left one is coming off this way. So in the ovaries is our lifetime supply. How do eggs form in the ovary? That was amazingly perfect timing, because we're going to talk about how that happens right now. So women have all the eggs that a woman is going to have. They form early on. They form at about they form by 20 weeks gestation. So if we remember back at the beginning of the lecture, how we had the gonadal ridges at about 6 weeks, and then if there's a Y chromosome, those ridges go on to become testicles. If there's not a Y chromosome, those ridges go on to become ovaries. If they go on to become ovaries, the X chromosome, the DNA, directs those tissue to begin making eggs. And that egg production actually begins as a top priority before formation of really any other type of tissue. Before the heart stops beating, before the brain is formed, the eggs are being made. And from about 5 weeks gestation until about 20 weeks gestation, there are about 6 million eggs which are formed. And then from 20 weeks gestation on, no more eggs are ever made. And in fact, what happens is that egg supply just decreases. So from 20 weeks gestation until birth, which is about at 40 weeks gestation, about 4 million of those 6 million eggs disintegrate. They undergo programmed cell death, apoptosis, they're gone. Which leaves us with about 2 million eggs at the time of birth. And then from the time of birth until the first day of a young woman's period, at menarche, at say 10 or 12 years of age, another 1.5 million of those 2 million eggs disintegrate. And that leaves us with about 500,000 eggs for the reproductive lifetime. And there are roughly 500 months between the first day of a girl's period and the last period of a woman's life. If you say that menses begins when a woman's about 10 years old and ends when she's 50 years old, that's about 40 years. If you say 40 years times 12, that's 480 months, so we round up to 500 months, okay? And we normally release 1 egg per month. So that's releasing a total of 500 eggs per lifetime. So if there are 500 months, and in that time we have 500,000 eggs which are available, it's almost as if you could count on there being 1,000 eggs available per month, of which the body chooses 1. So how can we choose just one of those eggs? Again, we're going to go to one of my fancy, actually, I'm going to just take a pause for a second here. We're going to switch up tape, and I'm going to take a sip. All right, we're good to go. Can everyone hear me? So now we're back to my fancy PowerPoint animation. But essentially, what this is supposed to represent is this is our pool of eggs, okay, which is present in the ovaries and continually diminishing. And this pool actually diminishes throughout a woman's lifetime, independent of many, many factors. So if a woman is on birth control pills, this pool is diminishing. If a woman is pregnant, the pool is diminishing. If a woman is having regular periods, not having regular periods, it doesn't matter. This is all kind of independent of that. This pool sort of slowly diminishes over time. And ovulation represents the rescuing of one of these eggs per month, usually, as the pool is diminishing. And they're sort of independent of each other. So what kind of happens is you can see this pool kind of diminishing down, and the eggs rotate through here, and ovulation is like one of these eggs being rescued per month as the rest of the eggs kind of fall off and don't get chosen. So how does this selection occur? Now, there's a bunch of genes which are involved in the selection of the eggs and the production of the eggs, and it's just a list of all these random different genes. And then there's a lot of hormones which are involved. Hormones of things that we hear about regularly, like LH, which stands for luteinizing hormone, FSH, which stands for follicle stimulating hormone. There's estradiol, there's androgens like testosterone and dihydroepiandrosterone steroids. There's another one called inhibin, which is kind of a bit more popular. Activin, anti-Mullerian hormone, growth factors, transcription factors. All of these things are involved in this process, and a lot of what my job is looking at these different hormones and trying to understand how they interact with the ovaries and how they direct this process. Someone asked about apoptosis. Yeah, the loss of the eggs that are not ovulated is by apoptosis, which is like a programmed cell death. If those eggs are not selected, if a certain egg is not selected to be the one that gets to ovulate, it will disintegrate or undergo apoptosis. And that's directed through these genes. So the way that it happens is there's kind of two stages of growth for an egg. There's the microscopic hormone-independent part of the cycle, and then there's the macroscopic hormone-dependent part, which is what we can see. So the earliest stage of an egg is the primordial follicle, and that's what forms embryologically. The primordial follicle changes to become the primary follicle, and then from primary it grows on to become a preantral follicle. All of those you cannot see on ultrasound or with the naked eye. The antral follicle, which is the stage after that, which is the stage that responds to all those hormones we were just talking about, that's visible. That's what we saw. That's what has this fluid clearing that eventually is what allows the follicular release of the egg. So the primordial follicle is the basic female reproductive unit, and it's present at birth, and it consists of a single layer of granulosa cells. Granulosa cells are very important cells within the follicle that produce estrogen, that support the egg inside of it. It also consists of an egg, which is sort of frozen at the first phase of meiosis 1. And this thing is about half the size of the normal egg, which we see at the time of ovulation. And so this is a micrograph of it. And so this is our primordial follicle with our single layer of granulosa cells and our oocyte, which is inside of it right here. And there are lots of these. This is what there are when we talk about there being 500,000 eggs. We're talking about those. Now, the next stage from the primordial follicle in growth towards becoming the egg that ovulates is that it becomes the primary follicle. And in the primary follicle, the granulosa cells become more cuboidal in shape, and they multiply. And this multiplication allows formation of gap junctions, which are the ways that those cells communicate with each other, and they improve nutrient flow and communication. And this is actually a process directed by the oocyte, meaning if an oocyte is removed from a primordial follicle, this process won't occur. The granulosa cells then form multiple layers, and there's a basement membrane that forms, separating the different granulosa cells. And that's what this one is, right here. So remember, this is the primordial follicle here with a single layer of cells. And here's our primary follicle, which now has these cuboidal granulosa cells going around it. You can see how this has now gotten a lot bigger, and this is on its way to maybe being that lucky egg that gets to ovulate. Now, from the primary follicle to a preantral follicle, we get greater enlargement. The egg itself goes from being 50 microns in diameter to getting larger to that 100 microns. There's a structure called the zona pellucida that begins to form, which is a clearing around the oocyte. The granulosa cells further change and theca cells begin to form. Theca cells are the cells that produce androgens. And at this point, we develop the FSH receptors. Now, FSH stands for follicle stimulating hormone. Remember, this is now going on to become a follicle. And the FSH is a common hormone that we hear about, which is we measure a lot in order to get a sense of a person's fertility. And this is the hormone that comes from the brain that goes down to the ovary, stimulating the growth of the follicle. So follicle stimulating hormone. So at this point, the preantral stage is when that egg develops the receptors to the FSH. And this is where it goes from being hormonally independent to hormonally dependent. And that's what this is supposed to represent. So now, these are all granulosa cells. This is the zona pellucida, and this is the oocyte. This is the nucleus of that oocyte. So now it's getting much bigger. So timing is everything, because to make it from that preantral stage to the antral stage, it requires the use of those newly acquired FSH receptors. And in order to use those FSH receptors, there needs to be FSH around. And this only occurs at certain times of the month. Does anyone know when we get that FSH coming in? Is there a point in the month in which we get a surge of FSH? This would be the point I would pick on somebody. Oh, I'll pick on Donna.
Is this the first day of your period?
Yes, well, yes, right around there. So yes, in the very beginning of the cycle, between... Okay, so Donna said, correctly, she said, is it the first day of your period when you get this FSH? And she's absolutely right. So in the early part of the cycle, we get a surge of FSH. And if at that time there happens to be some of these preantral becoming antral follicles that are at the right stage, their newly acquired FSH receptors are coming online just at the time that the brain is giving out this surge of FSH. And so that is right here. So in this drawing, this is representing the first day of the menstrual cycle. First day, 28th day. This is the typical textbook menstrual cycle. By the way, most people don't have 28-day cycles. I think something like 15 to 20% of women have 28-day cycles. Most people range around that to some extent. So I see patients who are sometimes very worried that their cycle isn't 28 days. It doesn't have to be 28 days. Anyway, that's a side note. So textbook 28-day cycle. The beginning of this cycle, what we see here is we see this little boost of FSH. That's what this red thing is. Right around the time of ovulation, you get another burst. But right in here, you get this little peak of FSH. So if you are a preantral follicle, right in this window here, remember, this is all cycle independent. You're going to be cycling through because you're just one of those eggs. So if you have to be cycling through, when this FSH comes online, then you can be recruited to possibly be the egg that gets to ovulate. This is the LH hormone. This is the estrogen hormone, which is in response, remember those granulosa cells? So remember, you have this preantral follicle that gets caught by this FSH surge. Those FSH then causes that antral follicle to start growing, and those granulosa cells inside the antral follicle begin making estrogen, which we see represented by the estrogen level coming up here. So that's kind of cool. So to continue its life as a follicle, that preantral follicle must gain its receptors during that specific window early in the menstrual cycle, just as Donna said. If the receptors form too early or too late, sufficient FSH will not be present to support its growth, and the result will be apoptosis, just as Kristen Ebert said. Am I allowed to say people's names? Okay, great. Good job, Kristen. So apoptosis is the fate of more than 99.9% of all primordial follicles. which in some ways is really sad. It's like a waste of all these great eggs. But in other ways, it just goes to the redundancy of the system, that we need to make sure that there are plenty of eggs there so that when we are ready and capable of reproducing, the eggs are there. And that's sort of the point of view that I take on this. So it's not a waste at all. It's all about preparation. So the antral follicle contains an antrum, or a cavity, and are visible on ultrasound. They're about 4 to 7 millimeters in diameter. And the oocyte inside of that follicle is about 80 to 100 micrometers. FSH and subsequently LH receptors become prevalent. And one antral follicle will eventually be selected as becoming the dominant follicle of a cycle. Many people, yes, Constance says it. Yes, we are all very lucky to be here. I think that's a true, I think it's always good to recognize that. It's amazing that any of us are here. It's like, it's just a strike of fate. So, yes, be happy to be alive. So, there's something called the antral follicle count. And the antral follicle count is directly related to the number of primordial follicles which are present. As that pool of primordial follicles decreases, less follicles will enter the recruitment process. And as less follicles enter the recruitment process, less follicles reach the pre-antral phase at the appropriate window, and then less follicles become antral follicles. Normally, we see about 6 to 8 antral follicles in a strong ovary, in a ovary that has good ovarian reserve. But as we get older, that number diminishes. So when we do an ultrasound, we do something called the antral follicle count. This is one of the ways that we assess a woman's fertility potential or ovarian reserve. And so this is an ultrasound right here, ultrasound picture. This is like a transvaginal ultrasound. This represents the tip of the probe, which would be inside the vagina. And that probe actually gets really close to the ovary. So this is the ovary. And all of these circles, here, 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 these all represent the follicles. So you're supposed to do an antral follicle count around day 3 of the cycle, which for a lot of people is kind of disturbing. Like, no one really wants to have a transvaginal ultrasound while they're on the 3rd day of their period. But I always tell them this is the best day for us to take a view of the ovaries. And it's somewhat subjective. This actually says it's somewhat objective, but it's actually not. It's somewhat subjective, because it's really, someone looking through here and being, that's a follicle, but maybe that's not a follicle, maybe that's not a follicle. So you kind of get a gestalt, a feel for how it's supposed to look. Just by looking at this, by glancing at it, after looking at thousands and thousands of ovaries on ultrasound, this is a good ovary in terms of its follicle count. Even if every one of these is not necessarily a follicle, if this is a blood vessel, if this is a low fluid collection, there's enough of these spaces that would represent a good number of follicles in a young, healthy ovary. So eventually what happens is one of those follicles becomes the dominant follicle. And that's what this looks like on ultrasound. So again, you have a couple more of these follicles, but as we get later on in the cycle, this is the follicle that's going to develop and ovulate. And remember that we go back to the very beginning of the lecture, we saw that picture with that kind of bleb that was extruding out the edge of the ovary. This is what that would look like on ultrasound. So you may see that just the very end of this kind of break open. This is all fluid, and inside here somewhere is a microscopic egg that we can't see. So this would break open, the fluid would come out, and with the fluid would come this little microscopic egg. And then that would fall down into that cul-de-sac of Douglas, and that's where we do the uterine dance, and the fallopian tube picks up the egg. So the fact that we only get one dominant follicle at a time is purposeful, because humans are only supposed to have one baby at a time. So there has to be a way of selecting only one egg at a time. And so that goes back to that whole FSH and the receptors thing. Because what happens is, if a follicle comes into that window, I want to make sure, I want to kind of highlight that window again. So essentially, remember, we have follicles that are cycling through at all times, regardless of where we are in our menstrual cycle. Excuse me. So if you have some follicles that are cycling through right in this window here, then they get the nod, and they get to change into becoming the antral follicles. Okay, so this is that window in the first few days of that cycle. So if that happens, then the F is supposed to say FSH induces production of, amongst other things, estrogen and FSH receptors. So the FSH causes production of FSH receptors. It's very self-serving. So the antral follicle, which responds most robustly to the FSH, will then produce more FSH receptors while it's producing estrogen. Then what happens is, as that estrogen increases, that estrogen travels up to the brain and gets the brain to start making less FSH. Is 6 to 8 antral follicles for each menstrual cycle. It's 6 to 8 antral follicles per ovary for each cycle. Yeah, that's in general. Some women have more, some people have less, but that's kind of an average number per ovary. I'm sorry, there was a question about how many follicles are per cycle. So 6 to 8 per ovary per cycle is kind of an average, maybe 4 to 8. So as one of those follicles, as the FSH, one of those follicles will respond more robustly to the FSH, and it will make more FSH receptors. As it makes more FSH receptors, that FSH causes it to make more estrogen. Okay, the estrogen will then go feed back up to the brain, and that will make the brain produce less FSH. As the amount of FSH diminishes, if you have more FSH receptors, you can kind of soak up that FSH, and the follicles with less FSH receptors will then kind of shrink away. And this is the way in which we choose a single dominant follicle. So as the estradiol increases, the FSH level diminishes, and this starves off the follicles without adequate FSH receptors. Meanwhile, the dominant follicle has those sufficient FSH receptors to continue growing and producing more estradiol, which kind of causes a further shrinkage of those other follicles. So remember, that's right here. We get this peak of FSH. There's a handful of follicles in this point which are able to respond to that and begin to grow. As the FSH kind of peaks up here, 1 or 2 of those follicles generally will respond more robustly, and whichever one ends up growing with the most FSH receptors, it starts producing estrogen right here, which travels up to the brain and causes the FSH to decrease. So if you didn't get in here just at the right time and make the right number of FSH receptors, as FSH decreases, you're a follicle that's going to start shrinking away. Because meanwhile, this bigger one that has all these FSH receptors is kind of soaking up the FSH that's there. It keeps on producing more and more estrogen, causing the FSH levels to go down further and further and further, making so no other follicles can grow. And so we get a single dominant follicle to grow. When the estrogen reaches a specific critical threshold, somewhere between 200 and 600 picograms per milliliter, negative feedback, which is, so remember, excuse me, the estrogen has been suppressing the FSH level. We call that negative feedback. So when the estrogen gets to a certain point, the negative feedback changes to positive feedback, and this causes an FSH and LH surge. Charge! The LH surge then initiates a series of events which ultimately lead to ovulation. And during ovulation, we have the resumption of meiosis. I don't know if you guys remember back before, we said that the egg at this point, which is inside the follicle, has been frozen in stage 1 of meiosis since birth. And at this point is when that egg now wakes up, which is amazing because it's been actually not, since before birth, that egg has been frozen in meiosis. So whether this is happening when a woman is 14 or 44, that egg has been frozen in meiosis 1 up until this point that it actually makes it through all of these stages and gets to ovulate. Excuse me. This causes luteinization of the granulosa cells. Remember, we talked about the follicle. At the time of ovulation, the follicle goes from being the follicular phase to the luteal phase. And this is luteinization, where those granulosa cells go from making estrogen to now making progesterone, which is what supports the later half of the cycle. And this also produces a certain amount of elasticity of that follicular wall so that it can break open. And it also causes production of proteolytic enzymes and prostaglandins. And these are what ultimately break down the wall of that follicle and cause it to break open and ultimately ovulation to occur. So this, remember, during this part of the cycle, as the estrogen is going up, 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 this is negative feedback causing the FSH to go down, 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 until we get to a certain critical threshold right around here, and it switches from being negative feedback to being positive feedback. And also we get this surge of LH. This is what we detect when we do an ovulation predictor kit. And right before ovulation, these hormones peak, and we get right before ovulation. And then we get, poof, ovulation. So that's kind of how it works. Let's see. Oh yeah, so this is my other model. So this is worthwhile here. Actually, is this a good time to take a break, you think? Or? Yeah. Okay. We'll come back and review this in a second. We're going to take a little break here, guys.